Okay. I know that many of you, as you think about injuries, and many of you physicians, particularly on the call or in the OR or checking a patient into the ED, will be echoing Dr. McCoy's sentiments here. Damn it, Jim, I'm a doctor, not a coder. But of course, Dr. McCoy, for all his advanced technology, he never seemed to look at a medical record, did he? And I'm confident he never had to submit a claim. But here we are in the next 50 minutes, unless we can be beamed aboard the Starship Enterprise, you'll hear about the general guidelines for coding injuries. And I apologize to the physicians in the room. We're not going to spend a lot of time on the general guidelines, and we're only going to talk about those that are related to injuries. I'm going to talk about how the chapters are organized, how the trauma chapter is organized from head to toe for the S codes, and then for multiple injuries, burns, poisonings, and adverse and toxic effects. I'm sure you've heard by now about this 7th character extender, and I'm going to talk with you about that. And then the external cause codes, which are equivalent to our E codes now. Injuries are going to hurt because it's the largest increase in codes. I think half of the increase in codes from ICD-9 to ICD-10 is in injuries. So I often joke to people, and it's only a joke, you're going to be fine with ICD-10 as long as you don't treat any injuries and you don't deliver any babies. Other than that, everything's good. But the reason that it's going to be more difficult is because location becomes much more specific, type of injury is specific, and then there's laterality. And there's a great increase in codes where there's with and without foreign body, with and without penetration into the peritoneal cavity. So we're going to be answering questions like that in order to select the most specific code. The 7th character extender for all injuries is really the villain when we think about why we're going from about up to 30,000 injury codes. It's because each injury code gets a 7th character extender. And let's say there were 3 extenders for my sliver in my finger. If I count that code with each of its 7th characters, it's now 3 codes. So I'll show you how that works. And then fractures gets very detailed with many more 7th character extenders, which you'll see. And then the equivalent to the E codes, the external causes, are greatly expanded. So when I look in the fine print at the start of the code, it's very similar to ICD-9. It says assign a separate code for each injury, unless there's a combination code. Code the most serious injury first. So far, so good. That's what we do in ICD-9. And superficial injuries like abrasions or contusions that are at the site of a major injury aren't separately reported. So far, so good. When we're thinking about injuries to nerves and blood vessels, if those are minor damages, then we're going to sequence the primary injury first. But when the primary injury is to the blood vessel or to the nerve, we're going to sequence those first. And that makes sense to us too. Now, we have these traumatic injury codes, and notice, if this is not your first session, you're not going to be surprised that we have ICD-10 codes start with a letter and then proceed to a number. So the traumatic injury codes in S00 to T14.9 series, we would not use those for healing of surgical wounds. So if you have a patient who has an abdominal surgery, we wouldn't use abdominal injury for one of those wounds, of course. And there are some aftercare codes, the equivalent of our V codes, person who is recovering from a certain type of condition. We wouldn't use the aftercare code when we're taking care of a patient who's in the healing period for a fracture. So that's, again, not too different from what we have in ICD-9. But here's one thing that's different. We have excludes. So in ICD-9, any of you who open your book, you see the main character, and then it says excludes, and it lists some things that this isn't. And in ICD-10, we have two types of excludes notes. excludes 1, and excludes 2. And we're going to look at this same code, S01, open wound of the scalp, and we're going to look at it in terms of the excludes 1 note, and then in another slide or two, the excludes 2 notes. So S01, open wound of the scalp, it has an excludes 1 notation. It excludes 1 open skull fracture, S02. So they're saying to you, if the patient has an open skull fracture, we're not going to code an open wound of the scalp. Those are mutually exclusive. If they're the same injury, you're going to code to the skull fracture. So they're telling you this is not your code. If you had your book open, or if you were working from a coding program that showed you everything, right after S01, it would say the appropriate 7th character is to be added to each category S01 code. So A for the initial encounter. This is the first time that I, the physician, I, the ED doctor, I, the surgeon, have seen the patient for this condition, for this open wound. Or D for a subsequent encounter during active healing, and S for a long-term after effect. And we're going to come back to those 3, but where you find them is at the start of the category code. And then you would see some other notations. It would say code also any associated injury of the cranial nerve, injury of the muscle and tendon, intracranial injury, or wound infection. So it just tells you, here's your code, assuming that's the code you want, and code in addition to that any associated conditions. But there's also an excludes 2 note. So we're still at S01, open wound of the head, and it excludes 2, injury of the eye and orbit, or traumatic amputation of part of the head. So what it's saying to you is, if the patient has both an open wound of the head and an injury of the eye and orbit, we want you to know that the injury of the eye and orbit can be coded in addition to the open wound of the head. They're not exclusive, but it's also saying to you, if what the patient has is an injury of an eye and orbit, don't use S01. So that's one difference in ICD-9 and ICD-10 is this 2 types of excludes notes. The first means this isn't your code, don't use it. And the second means this isn't what you're looking for, but if the patient has both conditions, then you code for both conditions. So now on the next 3 slides, we're going to go through them pretty quickly. It lists the blocks. That's what ICD-10 calls them. I think of it as the table of contents. What's included in this chapter and how is it organized? And these injuries to the body go head to toe. We could all do that: heads, shoulders, knees, and toes if we were together. And it starts with the least serious injuries, and I'll show you an example of that. So if you weren't having trouble with the index, you could look in the book and see the codes listed. It's not a really practical way to look up a code because there are too many of them. So those are the injuries. And then included in Chapter 19, we also have some T codes, which include some multiple injuries, foreign body, burns and corrosions, frostbite, and then poisoning and adverse effects. So we'll see some of these, but not all of these during this hour. ICD-10 differentiates between a burn and a corrosion, and I put a quote around this because this is from the guidelines. The burn codes are for thermal burns that come from a heat source. And we'd also use those for burns from electricity and radiation. And corrosions are burns due to chemicals. So we're going to have a different diagnosis code depending on how the patient was burned. And then, of course, burns are no different than now. Burns are classified by depth, by the extent or degree, and by of the body area, and by agent, by how it happened. For burns of the eye and the internal organs, those are classified by site, not by degree. As I said, we go from the head to the toe in this chapter, and it starts superficial. Superficial injury of the head, And then it goes down to traumatic brain injury and the crushing injury of the head. And it includes everything in between: contusions, lacerations, open wounds, nerve and blood vessel injuries, fractures. So even if what you're doing is removing a sliver, you're going to need to know about the injury chapter and the 7th character extenders. These codes are going to be used by many different types of clinicians. So when we think about this, of course, orthopedics, emergency department, trauma surgeons, they're going to be using this part of the book a lot. But so is anesthesia and radiology. Primary care often does walk-ins and for injuries. Many different clinicians are going to be using this chapter. And these next 3 slides are just to show you how specific it's become. And here's laterality: laceration with foreign body of the right breast, left breast, and unspecified breast. We hope we won't be using the unspecified breast. And there's no code for bilateral. If it was a ear infection, it'd be right ear, left ear, bilateral ears, unspecified ear. But for injuries, we don't have the option of a bilateral code. If this poor soul had a laceration with a foreign body of the right breast and the left breast, we would code both of those on the claim form. So if you're in the habit of writing ankle injury on your encounter form, that's not going to work very well. So let's say I would try to find ankle injury, and I came up with S93. That's the category. It's not a complete code, obviously. Dislocation and sprain of joints and ligaments of ankle, foot, and toe level. Now here are the excludes 2 notes. So that means if what your patient has is an abrasion, you don't want S93. If anything you see in the excludes notes is listed, then they're saying to you, S93 is not your code. But look at how many options there are for ankle injury. And these are just the superficial ankle injuries. We're not even on fractures, nerve and blood vessel injuries, amputations, crushing wounds. It excludes a strain of the muscle, a contusion, an abrasion, a blister. I won't read them all down for you, but you can see how many different types of injury we have. So we're going to talk about workflow in a little bit, but let's just think about how the diagnosis code is getting to the coder. Are we in our electronic health record and slowing down our clinicians for them to look up all of these codes? Are they handwriting it, and is it going to a coder? And then we're going to come back and query them. We're going to have to think about our workflow pretty carefully as we move to ICD-10. Just looking again at wrist sprain, is it right or left? Which joint is it, and which encounter? So these are just 2 examples. A sprain, S63.512A, sprain of carpal joint of the right wrist, initial encounter. And that 7th character A means initial encounter, whereas in the S63.521D code, sprain of radiocarpal joint of right wrist, subsequent encounter. Now at this point, if we were together, someone would say, I'm just going to code all unspecified codes because this is going to slow me down. I don't know what's going to happen with the unspecified code. I'm not one of these fear mongers who say they're all going to be denied and the sky is falling. An unspecified code may very well get an office visit paid in October of 2015. If you are pre-authorizing an MRI or a CAT scan or ordering physical therapy, I think we're going to see problems with unspecified codes just as we do now, with sometimes the payer requiring the more specific code. So we're just going to have to keep an eye on that. We want our coders to tell us right now what codes are being denied or what services can't be pre-authorized if they're unspecified, and we want to make sure we don't use those unspecified codes when we move along to ICD-10. Now, we used to say X marks the spot, but now I say X holds the place, because we also have this placeholder X code, and it's there to hold the space for future expansion. That always makes me smile, because we have 70,000 ICD-10 codes. No future expansion for me, thank you very much. or if we need a 7th character extender and we didn't have a code in the 6th position. So here, T76.4X5A is a complete and accurate code, adverse effects of tetracyclines for the first time you're seeing the patient for that problem. So let's look at 7th characters extenders, because as I said before, this is how ICD10 got so big. And the 7th character is not used in all chapters, and it has different meanings in different chapters. So it only means this in this chapter. A is for the initial encounter, D is for a subsequent encounter, and S is for a sequela, or a long-term after effect. And on the next 3 slides, I'm going to expand on just that A, D, and S. So A is an initial encounter when a patient is receiving active treatment. The subsequent encounter is used after active treatment during the healing or recovery phase. And S is for complications or conditions that are a direct result of the condition. This is totally new for us in terms of diagnosis coding. It's not a modifier. Modifiers are 2-digit CPT and HCPC codes. This is a 7th character extender that we never had on a diagnosis code. Sometimes we needed a 4th or 5th digit, but this is a new concept. And it doesn't correspond to CPT. So this doesn't mean new and established. And the way I know that for sure is because this is the complete descriptions from the start of the ICD-10 book. The 7th character is A, initial encounter, is used while the patient is receiving active treatment for the condition. Examples of active treatment are surgical treatment, emergency department encounter, and evaluation and treatment by a new physician. So the patient could have been injured last Thursday, went to the ED doctor says, tomorrow go to see orthopedics, or Monday get in to see the orthopedist, and the orthopedist will still use A for the first time he or she sees the patient for that condition. The 7th character is for subsequent encounter for after the patient has stopped having active treatment and is receiving routine care in the healing or recovery phase. And the examples they give of that are cast change, removal of internal or external fixation device, medication adjustment, follow-up of visits for the injury or the condition. And then the 7th character, the sequela, again, this is a new concept for us in diagnosis coding. It's used for a long-term after effect. So here's an example, a patient with a burn who has a scar. And 4 years later, that patient with the scar goes in to see the plastic surgeon. The plastic surgeon is going to code both the scar and the initial burn injury code. Don't ask me how the plastic surgeon is going to know what that initial ICD-10 code was, because they weren't to have treated the patient initially, with a 7th character extender of S. The S goes on the injury, not on the sequela code. So the forever, if that patient, or let's use an orthopedic example, patient who had a perfect repair of their ankle but continues to limp, or maybe it was an imperfect repair, I don't know, whichever it was. If that patient comes back to you 1 year, 8 years, 12 years later and says, I'm still limping from my ankle fracture, you're going to code 2 things. You're going to code the limping or the gait imbalance or whatever the problem is that the patient reports, and you're going to code the injury for the ankle fracture with this 7th character extender, the same code you used to initially treat their ankle fracture. Now let's talk a little bit about fractures, because it gets more complicated than that. Again, from the guidelines, a fracture not indicated as open or closed is coded to closed, and a fracture not indicated as displaced or non-displaced is coded to displaced. Now that's never going to happen to us, because our clinicians are going to tell us whether it's open, closed, displaced, or not displaced. But those are the guidelines. If you're doing a fracture, though, there are other 7th character extenders besides A, D, and S. So if what I have is a sprain, an open wound in the belly, a dog bite, I'll only ever use A, D, or S. But for fractures, there are more options, and here I've got them on the screen. Is it an initial encounter for a closed fracture, a subsequent encounter for a fracture with routine healing, delayed healing, non-union, or malunion? And the other thing, there are certain fractures that use the Castillo classification to decide on the seventh character. And in that case, for those fractures, we use A for a closed, B for an open, and C for an initial encounter of an open fracture with those three types. So you say to yourself, how in the world am I ever going to know which seventh character extender to use? And the way, and that depends on how you're finding or selecting your ICD-10 codes. If you are in a book, you're going to go to SA3, dislocation and sprain of joints and ligaments of the knee, and right under the includes and excludes notes, there'll be a box. And in my book, that box is sort of pink. And it says the appropriate seventh character should be added, and it gives me the choices of A, D, and S. Whereas if I'm on a different code, if I go to fracture of the foot and the toe for S92, then I get a choice of those other 7 codes, A, B, D, G, K, P, and S. And then there are those other, some certain codes where it's the Castillo classification that we need to use to report on our seventh characters. And again, the way you know if you're in the book is by going to the category code. If you're in your EMR or practice management system, it should prompt you. It should list all of them out with the right seventh character so you know which one you need to select for it to be a complete and accurate code. And the Castillo classification, the clinicians all know this, but for we coders, we're going to depend on our clinicians to tell us, and you can Google it and read about it, but it's about the amount of tissue damage, the mechanism of injury, and the disease, and the degree of skeletal involvement. So here, I'm going to just pretend I've gotten an encounter form from a clinician, and it said hip fracture on it. So I'm going to go to my index if I'm working in a book, and I'm going to look up fracture. And the first thing is, just like in ICD-9, you have to differentiate between a pathological fracture and a traumatic fracture. And the pathological fractures are in the musculoskeletal chapter. So when I go to hip fracture, it says hip, see fracture, femur, neck. And when I go to fracture, femur, neck, it says see fracture, femur, upper end, neck. You'd think it could have sent me there right away. And then it gives me some codes to tell me where to go in the tabular listing. When I go to S72 in the tabular listings, there are 16 different seventh character extenders listed there as options for me to select. Displaced, not displaced, open and closed, whether the encounter is the initial, subsequent, or long-term after effect, and the Castillo classification. So there are a lot of options. And if you're trying to look at it either in the book, it goes on for pages and pages, or if you're looking at it on the screen, it's hard to search just because there's so much of it. Because there's very specific locations, and I'm going to show you a couple of examples of those. I don't own and have never used, but I saw a demonstration of Codex, which any of the orthopedists on the line will know of, and that had a quick and easy search and made it easy for the physician who was looking for the code to find it. So here are just some examples, and none of these are have their seventh character on them, and none of them even have their sixth character. Because if I look at S72.02, displaced fracture of the epiphysis, I have my choice of displaced and non-displaced, displaced fracture of the epiphysis of the right femur, left, unspecified, non-displaced fracture. So I've just given you some examples about the locations here, but the S72 codes goes on in my ICD-10 book for 4 pages. That's how many codes there are. fracture of the base of the neck or the femur, unspecified fracture, articular fracture. It doesn't end. When you get your ICD-10 book, take a look at some of those. Colles fractures in ICD-9, is it open or is it closed? In ICD-10, we have right, left, and unspecified, and the seventh character. So here's a coding program that I use, and I'm going to show you where I find that in the next couple of slides. So when I look at Colles fractures, now it's showing me all the possible, and this is just the right radius, okay? So we would have the same screen for the left radius and the same screen for an unspecified radius. It's showing me, was it an initial encounter for a closed fracture, open fracture type 1 or 2, open fracture type 3A, 3B, 3C, and then I have my subsequent encounters, and was it an open or closed? Is it routine healing, delayed healing, non-union, or malunion for the subsequent encounters? And then the long-term after effect. So our very friendly, simple Colles fracture goes out. I can't do the arithmetic here, but it looks to me about 12 codes here, 12 codes for the right, 12 for the left, 12 for unspecified. Now, you don't have to use the unspecified code, so if you knock those out, there aren't that many codes, right? How about a laceration? Here's a cheek laceration. I go to the index, laceration, cheek. Is it external? Does it have a foreign body? It tells me for internal, see laceration, oral cavity. And then if I have codes for without foreign body, I'm going to have codes for with foreign body. Was it the right, left, the right cheek, the left cheek, or an unspecified cheek? So this does lead me to thinking about workflow. So who is selecting the diagnosis codes right now for clinicians? And who's selecting them really depends on whether you're on paper or whether you're in an EHR, and whether your EHR has predictive search in it, which I would say the Codex program has, and certain other programs that people have shown me. And you'll know if it has predictive search. Do you know how when you go onto Google, if I type in the word FA into a Google search box, it brings me up Facebook, because it predicts that I'm going to go to Facebook because I've been there before. If I type in what is predictive search and I spell predictive wrong, it brings up the results for what is predictive search, because other people have looked there for the definition of what is predictive search. So what predictive search does is it remembers where you've been and your favorites, and it shows those to you more frequently. And then it looks at what other people have done. And those are two functions that we wish we had in our electronic health record, because it's going to make looking up codes much easier. Mapping isn't going to work very well. So for some specialties, I'm going to use diabetes, endocrinology, a lot of their codes are going to map one-to-one to ICD-10. The descriptions of them may have changed a little bit, but it's essentially the same code. So if they have a EHR, it's probably already showing them both the ICD-9 codes and the ICD-10 codes. If you're doing trauma and you have an EHR that's showing you the ICD-10 codes, you're thinking, I don't have to worry, my codes are already there. But in fact, they are mapping to the least specific codes, and it can't tell whether it's what seventh character extender it should have, because we didn't have that function in ICD-10. So I think in most instances, it's going to be quicker and better for us to look up an injury code rather than try to map it or translate it from ICD-9. Now you say, my program doesn't do that. Underneath the second bullet, I have a site here, ICD10data.com. That is that image that I showed you earlier of the Colles fracture. That came from there. It is free. It does do translations between 9 and 10, so you can start with an ICD-9 code and see how it maps to ICD-10. And the search is reasonable. So if you don't have an easy EMR program, I'm going to suggest that you make this a button on your computer so that you can easily get to ICD10data.com, because it's going to be so much quicker. And I know how frustrating that is, that you have to go out of your program and then come back in and put the code in. But from what other what some of my clients have been showing me, it's going to be the least frustrating thing. If you're on paper, now we coders love our books. And what I find I often do is I use ICD10data.com as my index, and then I go to the book because I want to see the book. But so you should have a copy of the book in your office. But you can use ICD-10. It does have all of the includes and excludes notes, the things that I would want as a coder. So if you're on paper, make sure that you have access to this ICD10data.com and start to look up some of your codes in there. Now, so in-office charges are going to be a little easy. I guess I'm going to say they're going to be a little easier because of our EHRs. But how about the operative reports? If you're going to select any kind of a specific code, the operative report is probably going to be the best bet in order to code from. So the staff member, if you have a coder in your office, should probably look at the operative report. These handwritten charge slips that we've used for all of our professional careers, it's not going to work well in ICD-10 because your clinician is not going to be able to write enough on there for you to find a very specific code, and then you'll be querying the physician and slowing down claims. So we can talk a little bit more about that at the end if you want to. So if you have any questions about workflow or how it's going in your office, please put them in the chat box and we can come back to that issue. But going back to the issue of coding, we have in ICD-10 a table of drugs and chemicals. So that's in the index portion of the book, and it lists the chemical by its chemical name. And then the headings have changed a little bit. Poisoning accidental, unintentional, poisoning intentional, self-harm, poisoning assault, poisoning undetermined, adverse effect, and then this new concept of underdosing. Just like in ICD-9, we start in our tabular index and we find we find the chemical, potassium, we find which it is, oh, this was an adverse effect, and then we go to the tabular listing. And these require a 7th character because they're injury codes. An adverse effect, by the way, is when the patient has been prescribed the drug correctly, they picked it up, they took it correctly, but they had an adverse effect. They had a reaction to it. Whereas underdosing is when the patient takes less of the medication than prescribed. So here's a patient who has an adverse effect of lisinopril, took the drug according to prescription, but developed rapid weight gain. We go to our table in the index and we see the T46.0X5. We have our placeholder X in many of these poisoning codes, and we need a 7th character extender, so we would go back to our tabular listing and find out what we would need. And for the first time, you would need the A. Child and adult abuse are in this chapter, so some mental health professionals are going to get a shock when they try to code for these conditions. So if it's confirmed or suspected child and adult abuse, those are injury codes, and we're going to put them in Chapter 19. And if it's a past history of abuse or neglect, they're in the Z codes, the equivalent to our V codes now. I love how they name that. Factors influencing health status and contact with health services. They're back in the last chapter in the book. So here's the codes. T74, adult and child abuse, neglect, and other maltreatment confirmed. So we're going to use these codes when we have confirmed abuse, neglect or abandonment, physical, sexual, or psychological abuse. They're going to require a placeholder code because they don't have a 7th character, because these need an A, D, or S 7th character extender. And we're going to use an additional code, if applicable, to identify the associated current injury. So if you're in the ED, I think the ED doctor, and it's a confirmed abuse, the ED doctor is going to use this T code as well as whatever the injury was. I think if you're in orthopedics, you're going to want to start with the injury code first, personally. That's what I would do. Use an additional code to identify the perpetrator if known. Again, the ED doctor, family doctor, they will probably be doing that. Do you need to do that in orthopedics or radiology? I'm not so sure about that. T76 is suspected child abuse or adult abuse, neglect, and maltreatment. And these suspected codes are also going to use an A, a D, or an S. Sometimes when it's suspected, we have an injury, and if we do have an injury, we're going to code that as well as the suspected abuse. And again, if you're the orthopedist or the radiologist reading the x-ray, I think I would code the injury code first. Here's some examples. T74.12XA, child physical abuse confirmed, initial encounter, subsequent encounter, and sequela. So if we had child physical abuse and there was an injury, we would also be coding the injury. Now let me move along here to the external cause codes. These are equivalent to RE codes. And a year and a half ago, before we got this last delay and for October of 2015, there were a series of articles in the popular press. There was one in the Wall Street Journal. And they talked about how greatly increasing the ICD-10 codes were and gave some examples. Ran into a light post initial encounter, ran into a light post subsequent encounter. And since they didn't understand the ran into a light post subsequent encounter, they thought it was when someone had run into the light post twice. Or as I like to say, pecked by a parrot, subsequent encounter. Oh no, not again. So do you use these codes now is the first question. This is from the guidelines. There's no national requirement for mandatory ICD-10 external cause code reporting, unless your state requires it or your payer mandates it. So when I talk to coders and clinicians who are doing a lot of trauma, I'd say about half of them are routinely using the E-codes and some aren't. And some of them tell me that they use the E-codes because it keeps the payer from sending a letter to the patient saying, how did this injury happen? And that can delay payment, so that using the E-codes can be helpful. But if you're not getting rejections now because you're not using the E-codes, maybe you're not going to get rejections in the future for not using these external cause codes. The chapter is big. It goes from V01 to Y99. It's what used to be the E-codes. It's payer-driven, not ICD-10. Just like in ICD-9, we would never put that code in the first position. We put the injury first and then how it happened. And here's an example of an E-code. V11.5XXA. So here we had a code that was only 4 characters long, but I needed a 7th character extender for it because we use the 7th character extenders on the external cause codes, not just on the injury code. So we have 2 placeholder codes and then the A. But look at the description of it. Pedal cycle passenger injured in collision with other pedal cycle in traffic accident initial encounter. So we could have a pedal cycle passenger who's injured just because they fell off their own bike. I have fallen off my own bike. Or we could have a pedal cycle passenger injured with a motor vehicle accident. And then, of course, the initial subsequent encounter. But when I first started reading this, I said, what in the world is a pedal cycle? And then I thought, well, I guess it's because the World Health Organization made these codes up, because we don't talk about pedal cycles. But then someone corrected me and said, well, the patient could have been injured on a tricycle or a unicycle, not a bicycle. But I still think this whole concept of pedal cycle is odd. So we've got these greatly expanded traffic accidents, other types of injuries, intentional self-harm, and assault. They're detailed. We would be, now here's a place where unless you're receiving denials, I would not query the provider to oblivion about how it happened. So if I were back at that bicycle accident, and I couldn't really how many times are we going to go back, and what does it matter to the payer if I fell from a stock or if I had a collision? We're going to have to be careful about these. If we're seeing denials right away in the end of October, we're going to have to be more specific about it. But I think if there's an accident in the office, someone else has got to collect the information about how it happened in some detail as the patient is coming in. You know, I love that. As my ankle is on the side and I'm bleeding, you say to me, but were you on a step or were you on an escalator? Just what I want to hear. But the clinicians are not going to be collecting this level of specificity, so someone's going to have to do that if our payers are requiring it. In addition to this replacement for the E-code, for this external cause code, also optional are 3 types of occurrence codes. The place of occurrence, where did this pedal cycle accident happen? The activity code, what was the patient doing when it happened? That's often redundant with the external cause code, says the same thing. And this other external cause code for the status, was the patient a civilian? Now these are optional, but I'm sure the hospitals are going to do that. So that's the other thing, especially in the hospital. Our surgeons are not going to go and find out the detail about this pedal cycle accident. They're just not. They don't care. They just want to fix what happened. So the hospital, on the other hand, the coders in the hospital love these kind of codes. So perhaps when the patient is discharged, you can get this whole series of codes from the hospital rather than you having to read through the record. So again, these are optional other than the injury. So first we code the injury just like we do now. Next we use the external cause. Both the injury and the external cause require that 7th character extender. And then we have 3 occurrence codes. So some of you know I lived in Vermont. I just moved, but I lived there for almost 30 years. And I took a walk up Mount Ascutney one day, a hike. And when I got up there, huffing and puffing, I realized you could have driven up Mount Ascutney like this gentleman did, but he had other plans. So he drove up, and then he put on this caterpillar-like contraption, and he basically jumped off the cliff. Can you imagine? And there was another picture of him. He was soaring higher and higher than us, but I couldn't get that with my iPhone. So how are we going to code for this claim? I didn't want to give this gentleman any bad karma, so I gave him a very minor injury. Abrasion, right knee, initial encounter. We have that A on the end of it. We know it's an abrasion, not a contusion, not a laceration, not an open wound. No sprain. We have a external cause code, V96.10XA, hang glider crash, injuring occupant, initial encounter. So if there had been a hang glider crash, if he had bumped into someone, there would be a different code for a hang glider crash when you weren't the hang glider occupant. And then these 3 optional external cause codes. Where did it happen? It happened outside. I had to choose some kind of a specified code for that. Activity was hang gliding, and it was a volunteer activity. You couldn't pay me to do that, but I would have had the option. He was part of the military. He was doing it on the job, whatever. So you probably are going to need to use some external cause codes to get your claims paid, but I wouldn't pay too much attention to these occurrence codes. And if you have people telling you you need to do that, you should point out to them that they're optional, and I don't think that the payers are going to require them. Famous last words. If they require them, let me know. So let's just review. We have specificity, location, and laterality. That's what I really started with. We have, and all of these would require a 7th character that I haven't put on. That dash there is what I'm indicating that with. S30.851, superficial foreign body of the abdominal wall. That is, we have a sliver. S31.110, laceration without foreign body of the abdominal wall, left upper quadrant, without penetration into the peritoneal cavity. So you can see that we're going to have with and without foreign body, with and without penetration into the cavity, and very specific part of the abdominal wall. Puncture wound with foreign body of the right thumb without damage to the nail. Anytime we have the with and without, we know we're going to have many more codes for options. Poisoning adverse effects. We have a lot of specific codes, just as we do in ICD-9, but we have more of them now. And these adverse effects, whether it's self-harm, I took too many aspirin, whether it was intentional or accidental, underdosing or an adverse effect, these codes are going to require a 7th character extender. So let me just review the key tasks before implementation. So this was an introduction to injury coding. Obviously, I didn't go through all 30,000 codes or even 30 codes. So you're probably going to want to schedule some more detailed education. For physicians, it should be very specific. So you could look on some of the commercial payers' website, and I would focus on just those chapters that you need for the clinicians. So the trauma chapter, if you're in orthopedics, you should look at the musculoskeletal chapter as well, maybe the neurological chapter. Take a run a frequency report and see which codes you're using for which conditions. And then just have the surgeons look at the codes that are relevant. If you're a general surgeon, you're going to want to be in the digestive chapter. One of the problems for general surgery is they're all over the place. You've got to know the neoplasms, skin, digestive, some thoracic. But look at your CPT coding frequency report, and then have your clinicians focus on just those chapters. Now, if you work in just one specialty and you're a coder, then you probably can go ahead and just look at selected chapters as well. But there are all 21 chapters out there, so if you want to be certified in ICD-10, or there are 1 to 2 day boot camps, and if you're in a multi-specialty group, you probably want to do that. I always have testing on the slide, and then when I ask, is anybody testing, the payers won't let us test, which makes me nervous. If we're allowed to test, we want to test. If you have a software installed on your computer, your practice management or EMR system is on your computer, then you want to be on the latest version. So don't wait until August or September. Update today. Get on the latest version of your software. If you're on a cloud-based system, you're usually on the latest version anyway. We talk about a gap analysis. Very briefly, what that is just running a list of your most frequently used ICD-9 codes, and the ones that you use 50 or 100 times in a year. Pull the documentation for that and take a look. Could I code for this condition, for this injury in ICD-10? And if the answer is no, then what would you have needed? So what was missing to code? So I sometimes do that in presentations if we all have a book or a computer in front of us and say, okay, ankle fracture. Oh, well, I need to know if it's open or closed. I need to know if it's right or left. So that's the gap analysis, and then begin to communicate that to your clinicians. Mapping isn't going to work very well for injuries, in my opinion, as I've looked at those mappings, but you can take a look at mappings. And I gave you that website, ICD10data.com. It's the companion website to ICD9data.com. And if you go in and put in any diagnosis code to ICD9data.com, you can get the ICD-9 code, but it also will convert. It will show you some of the options for ICD-10. Be careful about that, though, because the code it often converts to is an unspecified code. And even though I don't think the sky is falling and we're going to all have every single unspecified code denied, we want to move as much as we can into the more specific codes as our payers tighten up some of their policies. If you have templates or order sets that have codes built into them, so you've built in this code for laceration repair on the shoulder or knee fracture. You've built those into a template. You need to update those, and you need to update order sets. Sometimes it's the order sets that take more time. And then reviewing of payer policies. So when we think about it, how do we use our diagnosis codes now? We use our diagnosis codes to get claims paid, basically, to establish the medical necessity for what we're doing. But we also use diagnosis codes to pre-authorize or pre-certify either diagnostic tests that we need or the procedures and surgeries that we are going to perform in our practices. And some of these have national or local coverage determinations or payer policies. So if you are performing a service that is covered by some of these payer policies, you want to go into those payers' websites and look at them and see if they have mapped to ICD-10 yet. And if they have, then you want to make sure you know what those are. Print those out for yourself. Okay, so I think we're coming up to the end here of the presentation, but I'm ready to take any questions about these issues in ICD-10 or other ICD-10 issues that you have. And if you do, type them into the chat box, and then we'll answer them.
Great, Betsy. We have a couple of questions so far, and there's still time for others to ask more if you'd like to. The first question we have is, we don't have an electronic health record. Do you have a suggestion about the best way we can structure our workflow for office visits?
So a lot of people were using paper encounter forms. And I want to tell you, if you've heard me talk about ICD-10 before, you've heard me say this, and I apologize. I loved a paper encounter form. In 15 seconds, the clinician could circle what was done, circle why it was done, order PT and an X-ray, and a return to clinic. Really, did that take 15 seconds? We loved it. Now, the disadvantage to that was on the back, we put our most frequently used ICD-9 codes. And in order to fit them on for most specialties, we had to use unspecified codes. So that just reinforced that we didn't code in ICD-9 to the most specific. If you're doing trauma in the office or in the hospital, you are not going to be able to use a paper encounter form with the most specific diagnosis codes. So I'm going to say we're going to, for the office, we're going to ask our clinician to write the most specific code possible. And then we are going to give immediate, quick feedback about the diagnosis coding. You're not going to be able to submit the claims unless the clinician is initially, you're not going to be able to submit the claim until you have a diagnosis code for it, and you're going to be submitting all unspecified codes unless the clinician is searching and looking in the book right away. I think the other option is to get some tablets, and it's too hard on the phone. I have a couple of ICD-10 programs on my phone. It's too hard to look at them on the phone. The phone's too small. But a tablet or a laptop or a window on your computer, you can then ask the clinician to select the ICD-10 code right from a program. So I don't think the clinician's going to want to use the book because the index is difficult. But I think you could be having your clinician select the code using some electronic tool so that you weren't querying them and submitting a lot of unspecified claims.
Great. Our next question is, since we don't submit claims during the global period, do we really have to use the 7th character extender and change the diagnosis code for the post-op visit?
Oh, that's a good question, and I'm glad you asked that. So we know that our patients come in and they're either in a 10-day or more likely a 90-day global period. So are we really going to take the time to, of course, we're going to find the old code there anyway. I don't mean the old code, the initial injury code with the A on it, and we would just need to change it to the D, or for a fracture, there are some more specific ones for D for routine healing, G for delayed, K for non-union, P for malunion. So if you're seeing them in the global period and you're not submitting a claim, I personally am not going to worry about that. Now we know that in 2017, we're going to lose the global period for services that have 10-day global now. And in 2018, there's going to be no global follow-up for services that now have a 90-day global period. So we're going to be reporting those separately. But I say we'll worry about that in 2017 and 2018. So personally, I wouldn't take the time to do it, certainly not in the first year, if I were not submitting a claim. If I were submitting a claim for the service, then I would take the time, obviously, to change that. But I think especially in the first 6 months or a year, for injuries, because like I said, injuries are going to hurt, we should be concentrating on getting those initial codes correct and as specific as possible. So, Holly, have we come to the top of the hour? Just about, huh?
We have, and there are no more questions. So I just want to thank everybody for joining us today. We'll try to get this recording up as soon as we can, and we'll send out a copy of the slides when we send out the link. Thank you so much, Betsy.
Thank you.